Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host and moderator for today's webinar. Today, Dr. Daniel Pine will present Child and Adolescent Anxiety, Psychopathology and Neuroscience. The Brain and Behavior Research Foundation funds research around the world that identifies the causes, improves treatments, and will ultimately result in preventative techniques and cures for mental illness. Since 1987, the Foundation has awarded more than $328 million in research grants. We are the largest funder of mental health grants outside the federal government. 100% of all donor contributions for research are invested in the grants given directly to our researchers who are working to find scientific breakthroughs in brain and behavior disorders such as ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, OCD, post-traumatic stress, and schizophrenia. I'm delighted to introduce Dr. Pine. Dr. Pine is Chief of the Section on Development and Affective Neuroscience in the National Institute of Mental Health. In 2000, he received a NARSAT Independent Investigator Grant and is a member of the Foundation's Scientific Council. The Council identifies the most promising research ideas to fund with Foundation grants each year. Throughout his career, Dr. Pine has engaged in research focusing on the epidemiology, biology, and treatment of brain and behavior disorders in children and adolescents. His areas of expertise include biological and pharmacological aspects of mood, anxiety, and behavioral disorders in children. Today's webinar will start with Dr. Pine's presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. You can submit your questions throughout the presentation. Following the presentation, I'll present your questions to Dr. Pine, and he will address as many as possible in the time allotted. And now, it's my pleasure to present Dr. Daniel Pine. Danny, the floor is yours.
Thanks a bunch, Jeff. So I wanted to start off by thanking all the many people who are here to listen to the talk and to give a particular shout out to BBRF, who is sponsoring this webinar, not only for the tremendous work they do in supporting research, including my research, as Jeff mentioned, but also in the things that they do to try to get the latest information in science to people in the community and to clinicians so they can best make use of that science. So the talk that I'm going to give for the next 45 minutes or so is very much in that spirit. It will be talking about current science, and it will also be talking about how to use this science in the service of addressing the current needs of clinicians, patients, and families. I'll also end by talking a little bit about where the future might lead, and I'll be talking about child and adolescent anxiety, both psychopathology and neuroscience. At the outset, I did want to note that I have no notable conflicts of interest in that I have no ongoing relationships with pharmaceutical companies, and I am currently employed by the National Institute of Mental Health. The things that I'm going to say, though, really reflect my own opinions and my own view of the data rather than the positions of the United States government. And I'm going to do my best to try to balance the things where we have relatively clear answers on the one hand, but also point out some of the areas where there are major questions. Now, there's going to be two basic parts to the talk. The first part, as you can see on your slides, is going to focus on clinical advances. And this is going to take us to roughly about 2:30, maybe 2:35. And there are going to be three main things that I'm going to talk about. I'm going to talk about longitudinal studies, I'm going to talk about family studies, and I'm going to talk about treatment studies. And I'm going to do this mostly for what we know about pediatric anxiety disorders, but I'm also going to do it for pediatric mood disorders in general, but major depression in particular. And the reason that I'm going to talk about anxiety and depression together is that one of the most important things to know about anxiety disorders is that they're a major risk factor for depression. And as you'll see in a minute, because of some of the differences between depression and anxiety, if we can spend more energy in treating anxiety, we might not only have an impact on anxiety, but we also might have an impact on depression. So after that first half hour or so, really talking about what we know clinically about anxiety disorders and depression in terms of what happens to children with anxiety disorders over time, how anxiety runs in families, and what we know about treatment, I'm going to end by talking a little bit about the future in the second topic that you can see on your slide, neuroscience, both about how the circuitry involved in fear among animals gives us ideas about diagnostic tests and brain imaging, but then also about how this knowledge on neuroscience and brain circuitry gives us ideas about new treatments. So let's start with talking a little bit about some of these clinical topics. And as I mentioned, I'm going to be talking mostly about anxiety disorders, but I'm also going to be talking about the syndrome that you can see in the middle of your slide, major depression. So major depression is a particularly common syndrome. Approximately 5 to 20% of adolescents might be affected by this, and it involves a symptom of persistent and pervasive sadness, or what we call anhedonia, which refers to the inability to receive pleasure from things that others find enjoyable. Now, symptoms of depression and anhedonia are relatively common. They're usually normal. And the thing that differentiates normal problems with depression from depression that is part of a disorder is that when depression is abnormal, it's what we call persistent and pervasive. So what that means when we say it's persistent, we mean that a child or an adolescent who is having abnormal problems with depression or a diagnosis of depression, their symptoms will be present every single day. They will not have a single day over a 2-week period where the symptoms will not be present. Moreover, these symptoms are what we call pervasive, which means that we see them most of the day in most settings. We see them at home, we see them in the schools, and we see them when kids are with their friends. Now, this is a relatively clear distinction. It's relatively rare for kids to have abnormal problems with depression as part of the diagnosis of depression. When it does happen, we can see many signs of what we call impairment. Children with abnormal depression will miss school, their friendships, and their family life will be adversely affected. We see a unique relationship between age and gender as this diagnosis of major depression is concerned. Major depression is relatively rare before puberty, so that's the early teenage years in girls and boys, and it's equally common in boys and girls, again, before puberty. After puberty, we see a dramatic increase in depression, particularly among girls, such that about twice as many girls are affected by depression than boys. The issue with depression is that once a child has developed an episode of major depression, it's frequently recurrent. Even when it goes away, it often comes back. And that's why we need to think about what are the ways to prevent depression before it really begins, and this is where anxiety disorders come in, as I'll talk about in a second. So I'm not going to speak about bipolar disorder at all, but I will note that there is a lot of controversy about how common bipolar disorder is, and the most important thing to take away from the current webinar is that the current thinking is that bipolar disorder in children and adolescents is very rare, much rarer than major depression, the disorder that I'm talking about right now, and far more rare than the anxiety disorders, which I'm going to talk about next. So anxiety disorders come in many flavors, and usually we divide problems with anxiety into three main groups. The first group is classically characterized by something called obsessive-compulsive disorder, or OCD, and this involves very particular concerns about specific, relatively irrational events. So the child with OCD might be concerned that he has sinned, or that she has forgotten to do a very particular thing. And what we see in OCD is when these concerns happen, the child will have behaviors that are designed to reduce the concerns that they have. So a child who thinks that they've sinned will pray repeatedly. A child that thinks that they've forgotten something will check. A child who thinks they're dirty will wash. And we know a lot about the underlying biology of OCD, and we know that it's different from other anxiety disorders. The second group of anxiety disorders classically include PTSD, or post-traumatic stress disorder. And these anxiety disorders develop after a child has experienced a traumatic event. And that's an event that is extremely frightening to the point where the child thinks that their life is in danger. Like OCD, PTSD is different from the other anxiety disorders. So we think of PTSD and OCD as two separate variants of anxiety. And these two variants differ from this third group that includes a whole mix of conditions: phobias, generalized anxiety disorder, separation anxiety disorder, social anxiety disorder, panic disorder, and a range of other syndromes. And you can think for the current talk that we're going to spend most of the time talking about this third group of anxiety disorders. I will occasionally mention what we know about OCD or mention what we know about PTSD, but for the most part, I'm going to be talking about these other anxiety disorders. Now, as a group, these three families of conditions are exceedingly common, far more common than major depressive disorder. As many as half of all children and adolescents at some point might have one of these disorders, with most of them having a disorder in this third group. Now, we talked about the distinction between normal and abnormal depression, and we said that that's relatively easy to make. It turns out that that's much easier to make than the distinction between normal and abnormal anxiety. And this is partly because anxiety is so common. And anxiety can be adaptive. When we're afraid of something, it can keep us away from a genuinely dangerous thing. For families and clinicians who are struggling with this distinction, the main way to make the distinction between normal and abnormal anxiety is to think about the idea of avoidance. Anxiety is most easily recognized as abnormal when it leads to impairment through avoidance. So the child with social anxiety disorder will avoid social events. They'll avoid parties, they'll avoid speaking in school, and by causing trouble for this child, we can recognize anxiety as abnormal through that symptom of avoidance. We talked about the relationship between age and gender in depression, where it's after puberty that depression becomes particularly common in girls. This relationship is different in anxiety, anxiety is far more common in girls than boys from a very early age. From the first years of school, anxiety is more common in girls than boys. And because we see what we call this gender difference before puberty in anxiety, that provided the field with initial clues about this relationship between anxiety and depression. But when we did longitudinal studies, and I'll be talking about some of those in a second, we saw that anxiety very frequently predicted major depression. And that's relevant because it emphasizes how important it is to treat anxiety, because not only might we reduce suffering and impairment in children with anxiety, but we might reduce this long-term risk for depression. So the best kinds of studies to look at this relationship between anxiety and depression are what we call longitudinal studies. And this slide shows you the results from one longitudinal study that I've been involved in for the last 20 years. And this study followed a group of children living in communities in New York State as they passed through adolescence, and we repeatedly conducted diagnostic assessments on these children and adolescents and followed them as they became adults. And there were about 700 of these children that we followed from childhood through adolescence into adulthood, and this slide illustrates the relationship between having an anxiety disorder during adolescence, at some point in adolescence, and having either a mood or an anxiety disorder in adulthood. And there are three main points to take away from this slide. Point number one, anxiety was exceedingly common here. About a third, or 253 out of the 679 adolescents, had an anxiety disorder at some point during development. Number two, it was usually transient. It usually went away. From among these 253 adolescents with anxiety disorders, 191 of them were fine when we saw them as adults. Not only did they not have anxiety disorders, they did not have a mood disorder either. So point number two is anxiety usually goes away. Now, a lot of people conclude that anxiety is not very important because it usually goes away. But that would be the wrong conclusion because of this third finding. And this third finding shows that when we look at the adults who are affected with a mood and anxiety disorder, and there were 98 of them here, what we see is the overwhelming majority, or 62 of the 98, had their problems start with a childhood anxiety disorder. So what these three findings tell us is that while anxiety disorders are very common and they usually go away, they're particularly important because that subgroup of kids with persistent anxiety disorders will grow up to account for the majority of adults with mood and anxiety disorders. And therein lies really the importance of trying to treat childhood anxiety disorders. Anxiety disorders also run in families, and there have been two kinds of studies that we've done to look at the nature of this relationship. One of them looks at the relationship between depression in parents and anxiety in their children. And what we find is that parents with a history of depression have a very high rate of anxiety in their children. And that's also consistent with this idea that anxiety is many times the beginning sign of risk for depression. And then the second set of studies looks at the association between depression in parents and anxiety in parents and early behaviors within the first 2 or 3 years of life that are risk factors for later anxiety. And we call this the temperament of behavioral inhibition. And what we find is, much like the studies in slightly older children, children in the school age or adolescent years, we find that young children, preschoolers, who are born to parents who have either mood disorders or anxiety disorders have higher rates of this inhibited temperament that looks at an extremely high level of shyness relative to children who are born to parents without mood disorders or without anxiety disorders. Now, these associations that run in families are relatively complex. We don't think that there's any one factor that accounts for this transmission. Both genes and the environment are involved, and if we had to weight which one is important, we would say that the environment actually plays a bigger role than genes, but genes clearly play a role as well. All right, so we talked a little bit about symptom presentation and outcome, and we just talked about familial aggregation. Now, in the last 15 minutes or so of this first part of the talk, we're going to talk about treatment. And again, we're going to contrast what we know about depression, where the story is not bad, but not as good as we would like it to be in terms of what the data tell us about treatment, versus the story in anxiety disorders, where the data are quite promising. And we're going to talk about two general kinds of treatment. We're going to talk about medications, and we're going to talk about psychotherapy. And for the medications, we're really only going to talk about the selective serotonin reuptake inhibitors, because this is the only group of medications where research has been conducted that allows us to draw firm conclusions about safety and efficacy. So let's talk about major depression first. So what do the data show in terms of efficacy of these SSRI, selective serotonin reuptake inhibitor medications? So the data are okay. There are two medications, fluoxetine, which goes by the brand name of Prozac, and citalopram, which goes by the brand name of Lexapro, that have FDA indications for the treatment of major depressive disorder in adolescents. And that's one of the few times that I'm going to make a statement like that, where there is an actual FDA indication. There are very few FDA indications for mood and anxiety disorders. These are two of them, Prozac and Lexapro for depression. There are other SSRIs, including Prozac, that have FDA indications for OCD in children and adolescents, obsessive-compulsive disorder, but there are actually no medications that have FDA indications for any of the other anxiety disorders, either PTSD or the other anxiety disorders in children and adolescents. Other SSRIs have been studied. Sertraline, which goes by the brand name of Zoloft, has been studied in major depressive disorder, and there's some evidence that it can be helpful, but again, not as strong as fluoxetine or citalopram. And then the other agents, really, there is not that strong of evidence at all to suggest efficacy in major depressive disorder. So this is somewhat surprising, and it gives us all a little bit of pause. And there are a couple issues to think about. One issue is that the data are clearly stronger in the treatment of adult depression, but the data are actually not that strong even in adult depression. SSRIs are clearly reasonable treatments, but we clearly need better treatments, both for the treatment of adolescent and childhood depression, but also adult depression. Second, do we really think that there are meaningful differences among the SSRIs? Well, we're really not sure. Probably the most relevant thing is that the half-life of fluoxetine, Prozac, is relatively long. And we think that this might be meaningful because what that means is that if a child misses a dose of fluoxetine, Prozac, the child is less likely to be affected by that missed dose. And we think that might explain the stronger data for fluoxetine Prozac. That also has a downside, however, in that if a child has an adverse reaction, it also might mean that fluoxetine Prozac hangs around longer, and that the adverse effect might also not go away as quickly. There are also a lot of differences in terms of how these studies were done that might explain some of the findings that we see. So SSRIs are a reasonable treatment, but again, not as good as we would like them to be. Now, the problem really starts when we start thinking about, well, what are the other treatments that are available in the treatment of pediatric major depressive disorder? And besides the SSRIs, the next best treatment is probably cognitive behavioral therapy, or CBT. And here you see data from a particularly important study, one of the most important treatment studies ever done on adolescent depression, a study called the TADS study that directly compared the efficacy of fluoxetine, which is Prozac, CBT, which is cognitive behavioral therapy, and their combination relative to placebo. And there are two main findings to take away from this study that you can see illustrated right here. So this shows you the four treatments. So right here, this first line shows you symptoms over time to placebo. And what you can see when you look at this line is that placebo does have some clear effect in that the symptoms go down with time in the individuals on placebo. When you look at it, and you can barely see it, if you look at these black triangles, there's another line right on top of the placebo line, and that is the line for CBT. So this study is quite concerning in that it suggests that CBT is no better than placebo for the treatment of adolescent depression. Now, there are other studies that have come out since then that suggest that CBT might be more effective than demonstrated in this study, but the findings remain that CBT is somewhat of an issue in the treatment of adolescent depression. All right? The second thing is, if we look at these two lines right here, we see that fluoxetine is clearly effective. And while fluoxetine with CBT is a little more effective than fluoxetine alone, the second bottom line is that the data show that fluoxetine is more effective than both placebo and CBT. So what this tells us is in adolescents with depression, fluoxetine should be the first-line treatment. Now, I just got done telling you that it's not that great of a treatment, and that really brings home how much more work we need to do in coming up with better treatments for depression. So definitely stay on the line, because the news definitely gets better, and I don't want you to miss that. The story is very different with the anxiety disorders. All right, so we're going to talk about the same two treatments, SSRIs and CBT, but there's going to be a very different story. So the first thing to say is that unlike with major depression, many other SSRIs besides fluoxetine have been shown to work, even though they don't have FDA indications. So fluvoxamine, which is Luvox, has been shown to work. Prozac, which is fluoxetine, has been shown to work. And here you see a very important study for sertraline, which is Zoloft. So the first thing to say is that more of the SSRIs have convincingly been shown to work for pediatric anxiety disorders. The second thing to say is that the data are more convincing in that the findings are more consistent across the studies, and the magnitude of the benefit is larger. All right? So while SSRIs are okay treatments for adolescent depression, they're really pretty good treatments for adolescent anxiety. They're also pretty good treatments for adolescent OCD, but even here, when we compare the response of SSRIs in adolescents with OCD and adolescents with anxiety disorders, the response looks better in adolescents with anxiety disorders than it does with adolescents with OCD, but not other anxiety disorders. And then the third thing to say is that CBT is also a good treatment. So in this yellow line, this is very much like in the last study where we talked about CBT. And if you remember, this is a line for CBT and anxiety. And remember, in the other study on depression, this line stayed right up here on placebo. Here we see that CBT is also effective for anxiety, and this purple line is the line for sertraline. Here we see, unlike in depression, where the medication line was lower, here for anxiety, the medication line alone is similar to the therapy line alone, and the combination line, this is sertraline and CBT together, really was the best treatment. So what this tells us is that we have more options in anxiety disorders than we do in depression, and the response is better. And this again brings home this point that one of the reasons to treat anxiety disorders in children and adolescents is not only that they reduce suffering in children with anxiety disorders, but the response is much better than it is in depression. Now, there are concerns. Before we talk about the concerns, this just summarizes what I just told you, that the response rate is higher in anxiety than it is in depression, and then also the relapse rate is higher in depression than it is in anxiety. So again, that brings home this idea that it is really important to treat anxiety. So as I was mentioning, there is a downside, and some of you might have heard about what has been called the black box warning on the antidepressants. And the black box refers to the most stern warning that the FDA can put on an antidepressant medication. And about 10 years ago, this controversy emerged about the relative safety of the SSRI medications in particular, but also other antidepressant medications in children and adolescents. And these data were the data that the FDA reviewed, and I was part of that review. The data that you see on this slide led to these concerns. And what these data show you is the association between using an antidepressant and developing thoughts about suicide. These data are not for completed suicide. The data did not suggest that antidepressants increased completed suicide. They were associated with thoughts about suicide. And what this slide shows you is in different age groups, children, late adolescents, so this is 18 to 24, young adults, middle-aged, and the elderly, if the dot winds up on this side of the graph, that would tell you that placebo is better in terms of associations with thoughts about suicide. If the dot ends up on this side, that would tell you that antidepressants are better. And if you look, you see that the dots fall along this line here. Before age 25, the dots suggest that placebo is better and antidepressants are worse, meaning that antidepressants are more associated with thoughts about suicide. And then right around age 31, the opposite is true. Antidepressants are better. So this is a real effect. Practitioners and parents need to be aware that there is this tendency when young adults, adolescents, and children have been prescribed antidepressants, there is this tendency to develop thoughts about suicide. However, this tendency is less common than the beneficial effects of antidepressants. And while one does need to be aware of this, it should not discourage a practitioner or a parent from providing treatment to a child with a mood or anxiety disorder if they need an antidepressant. This might, particularly in the area of anxiety, this might move you to try cognitive behavioral therapy before you try an antidepressant. But remember when we talked about in depression that fluoxetine was better than cognitive behavioral therapy. So despite the presence of these data, still the SSRIs are the first-line treatment for children and adolescents with depression. All right, so we're finishing up with this main clinical part of our talk, and what can we say about treatment? The SSRIs are very effective in the treatment of pediatric anxiety. In depression, only fluoxetine and citalopram, that's Prozac and Lexapro, have clearly been shown to be effective, and they have FDA indications. And then finally, we just finished talking about this increased risk of thoughts about suicide with SSRIs. This is a real effect, but the magnitude of the effect is small. You need to be aware of it and look out for it and be cautious. But in a child with depression or a child with anxiety who has not responded to CBT, SSRIs are still a good treatment. So in the last 5 or 10 minutes, let's talk a little bit about the future. Where is neuroscience going to get us? And there's a great deal of excitement about neuroscience, and it's clearly going to move the field forward. And that's because this gives us a precise understanding of how the brain functions, and ultimately is going to help us understand what causes mental disorders in children, adolescents, and adults. And as you'll see in a minute, this will generate ideas about new treatments, and these ideas are actually coming out now, and one day it will also generate ideas about new diagnostic tests. And we're going to talk about the area of cognitive neuroscience in a minute. There's also a great deal of excitement about genetics. We're not really going to talk about genetics in this talk, mostly because in the area of anxiety disorders, the field is still fairly far off from using the insights from genetics to develop breakthroughs. And as you'll remember, when we talked about how anxiety runs in families, we talked about the importance of the environment as maybe being even greater relative to genetics. However, as we start to talk about this, the listeners really should remember that research in this area is very, very early. And while it's promising and exciting, it's nowhere near ready to be used for the routine care of patients with anxiety disorders or depression. So we're going to talk a little bit about implications for diagnosis. We're fairly far off here using brain imaging, either in affected children or in at-risk children. And then we're going to talk a little bit more about treatment, where again, insights are emerging that could be clinically relevant in the near future, meaning perhaps as early as 5 years from now. So the main brain imaging method we use in children is something called functional MRI, or fMRI. And the excitement about fMRI relates to what is depicted on this slide right here. And what this slide shows you is that when blood flow in a certain part of the brain increases, the brain actually has its own what we call endogenous contrast agent. And what that means is, just based on the changes in the magnetic properties of the brain during normal brain function, with very fancy computers, we can use non-invasive methods to take pictures of those changes in the brain. Now, there's been a great deal of interest in looking at changes in the brain using pictures like the ones that you can see illustrated here, just pictures of face emotion displays, to assess functioning in this brain structure that you can see illustrated right here. This is the amygdala, and you can imagine that this is an individual who is looking right at you, and the amygdala, each right and left amygdala you can see located on this picture basically behind the eyes. And what we find both in major depression, or MDD, and anxiety disorders is that there's an association between an increased response, an increased sensitivity to mildly threatening stimuli in the amygdala, and levels of depression and levels of anxiety. This is a clear and a replicable association, but it's not sufficiently strong that we're going to be able to use any of these techniques anytime soon as a diagnostic tool. we still don't understand nearly enough to make use of the brain imaging measures in this way. Now, there is more excitement, however, in using this information that we get from brain imaging to start thinking about novel treatments. So in research on anxiety, one of the things that we've learned about this amygdala response, and you can see it illustrated right here, is that we've learned that this response happens incredibly quickly. So this shows you what we call an attention-orienting response. And you can see as this individual is walking through the woods, you can see that this snake captures his attention right here. So through brain imaging studies, one of the things that we've learned is this amygdala response right here, and you can see this response is illustrated by this picture of the snake, which is fairly crude. We've learned that this response happens very rapidly, so rapidly that we are not even aware of the response when it unfolds. Because of that, we have to tailor the kinds of treatments that we use to get at this response that operates below the level of awareness. And one of the ways my group and others has been doing this is developing video games. And these are video games that we think can be used therapeutically to actually reduce the levels of anxiety that an individual experiences. And we've been doing studies with these video games here at the NIH, and they actually are fairly promising. However, we are not nearly ready yet to use these kind of video game treatments routinely for routine treatment for children in the community, but as compared with developing brain imaging measures for diagnostic tests, we're much further along when it comes to things like these kinds of video games, to the point where it's not ridiculous to think that we might have therapeutic video games sometime in the next 5 years that are developed based on what we're learning about how the brain processes fear. And we think about how these video games work very much like this slide is depicted right here, like hitting a baseball, and that Ted Williams, and that's who's depicted in this slide here, when he would teach people how to hit, he talked about there being two components to hitting. One, you think about relatively slowly, and you can see this illustrated here, where this picture shows the strike zone. And Ted Williams taught his hitters to think fairly slowly about where their best pitch was. So this was Ted Williams' best pitch right here, where he wanted to hit a pitch that was delivered in there, and he would think about that fairly slowly. And we can think about that as the types of things that we teach people in cognitive behavioral therapy about where they should attend. However, when we're hitting a baseball, there's another thing. You don't have to just think about the strike zone, but you have to practice swinging the bat over and over and over again. And we think about this attention response as very similar to swinging the baseball bat. So cognitive behavioral therapy can help by teaching kids how to do some of these slowly deployed things, like focusing their attention on certain things when they're nervous. But some of these things happen too fast for kids to be taught simply by telling them what to do. They might need to practice their attention deployment, and that's where we think things like video games come in. So the last thing to talk about is the research that has been done in rodents using a procedure called fear conditioning, and this procedure illustrates what happens in a rodent when a neutral stimulus such as this tone is paired with an aversive stimulus such as this shock. And the rodent learns to fear both this tone and this cage. And the important thing about this observation is that we've learned a great deal about the underlying neural architecture and the molecules that you can see illustrated here that allow the rodent to learn about this fear experience. And as we've learned more about these underlying molecules that you can see illustrated here, we've generated a bunch of new ideas about novel medications. Sometimes they're medications that have not been used at all, and they're completely new medications that are being developed right now. And other times, there are new uses for medications that might be used more safely or in a way that's more tolerable. Now, this research is quite promising in adults. It's also promising in children and adolescents, but because of some of the concerns about medications, research developing some of these novel compounds based on this work done in rodents is somewhat behind the research that I just described that's focusing on video games. So I think the bottom line to take away from this neuroscience research is that it's extremely exciting and extremely promising. It's clearly going to change the field dramatically over the next 20 years. However, the most promising recent things to happen are going to be novel treatments. And I just talked about some of these novel video games, but then also some of these novel medications. Things like new brain imaging tests are going to come much more slowly. All right, so to wrap up, I really spent time doing two things. First, I summarized what we know clinically, and there I talked about some of the features of both anxiety disorders and mood disorders, in particular major depressive disorder, and I contrasted the symptoms of these two different kinds of syndromes. I talked a little bit about familial aggregation, but then I talked in a fair amount of detail about both psychotherapy and medication, again, for major depressive disorder, but also the anxiety disorders. And I made the point that we tend to do better in the treatment of anxiety disorders than we do in the treatment of depression. And this really drives home the point about how important it is to treat anxiety disorders. And then I closed up by talking about some of the research on pediatric anxiety disorders with novel treatments, and you can see a number here. If you're interested in enrolling in any of the studies at NIH, you can dial the number that's illustrated there. And then if you have any questions for me, I do answer the phone actually. If you call this number, don't call it now because I'm on the phone right now, but I will pick up the phone and I'm happy to talk to clinicians and families. I will tell you, I tend not to talk about individual patients just because that's the kind of thing that should really be handled with a clinician and a patient after a thorough, careful evaluation. But I'm happy to expand on any of the points that were just raised in the webinar that I'm finishing now, or any of the points that we don't have time to get to in the 10 to 12 minutes we have for questions. So with that, I will end the slideshow and pass it back over to Jeff, who will lead us in questions.
Danny, thank you very much. Your presentation was extremely clear, and the research that you do, the knowledge that you have, you're able to present in a way that's very user-friendly for lay people. So thank you. Thank you for that.
Great.
We do have a number of questions. One question that a number of people asked, and I won't pose it in the way of an individual, but just in a more general way, if a adolescent responds to one of the medications that you described for anxiety, what's the typical time frame that you would have them continue to stay on the medicine versus stop the medicine and see how they're doing without medicine?
So that is a wonderful question, and I'm really glad that you picked that one, because I would say when I give this talk, that is probably the best, most important question that comes up. And it's important for a couple reasons. One reason is that that's an area where we really need a lot more research, that it's hard to give a definitive answer about it. The second thing to say is I have a somewhat unusual opinion or take on this matter, and I'm going to go through it, and I'm going to go through it somewhat carefully and cautiously and say right at the beginning that I tend to be somewhat more cautious than many clinicians. So let me say that at the outset. The third thing to say is that this really has to be a discussion that happens between parents and clinicians. And the way that I have this discussion is that I really like a child who has responded well to have 1 full year where they have done well. So that means that I really do not like to discontinue the medication until a child has had 1 year, all right? After 1 year, what I do is I sit with the patient and I sit with the parent and I look for the first low stress time period, and we at least talk about, do we want to lower the medicine? If it were my child and my child had been symptom-free for a year, I would want to lower the medicine at that first low stress period. I would say no more than half of the children that I treat are the parents willing to do that. All right, and the reason why is there is a reasonable chance between about 1/3 and a half of kids will relapse when you lower the medicine. Now, my feeling is I want to know that. As a clinician and as a parent, I want to know which child needs to stay on the medicine and which child doesn't, and the only way you can really find out is by lowering the medicine. And I'm more comfortable taking that chance than just continuing the medicine. That said, it can be quite disruptive when you lower the medicine and the child relapses. I have never had a situation where I couldn't have the child get back to where they were before I lowered the medicine, but it can take many months, up to 6 months. I will tell you, after 2 to 3 years, I do become quite uncomfortable. And after 2 to 3 years, I usually insist that we have a trial period off the medication. And again, it's very variable in terms of the outcome. Maybe half of the kids do well for a substantial period of time, a year or longer, but a good proportion of them relapse. So is there more I can say about that, Jeff, or did that pretty much handle it?
No, that was, I think, very helpful and really described it in a way that makes sense for people, because these are difficult decisions. Parents are afraid for their child to relapse. On the other hand, people have concerns about being on medicine for an extended period of time. So it is a pull and a push. You spoke about when wanting to do a trial to lower the medicine, a period of low stress for the child. What is, in your experience, the role of stress, and are there things that parents in general can do to help their children sort of decrease some of the stress that kids are under these days?
Yeah, so that's another, boy, that's great that you picked these two questions, because that's probably the second best question that I get. And there are a couple things to say about this one. The first one is there is an incredibly strong relationship between stress and anxiety. One of the strongest associations that we see between anything in the environment and any mental health problem. So that's number one. Number two, the child's perception of the stress is particularly important. All stressors are not experienced by all kids the same way, and the degree to which a child tells you that they're upset and the degree to which their normal activities are disrupted by the stress is the most important thing to take note of. Number three, there's a sensitive balance point between too much stress and too little stress. I think a lot of parents, and I'm a parent, and I think this way as well, want to eliminate all stress from the life of a child. Particularly for kids with anxiety, we see that having no stress is every bit as disruptive as having too much stress. So then when we follow kids over time, we see anxious kids who are not exposed to stress, who are not pushed to face their fears, as we say, do every bit as poorly as anxious kids who are exposed to too much stress. So the last thing to say is this is really where cognitive behavioral therapy really comes in, kind of working with an expert who's seen many, many children and can work with parents to find this right balance point. That's probably the most important thing that you can do. There is a wonderful book that I regularly tell parents to get, and the book is called Helping Your Anxious Child, and it's written by Ron Rapee, R-A-P-E-E, and colleagues, and it kind of goes through how to try to tailor these stress exposure experiences.
Very helpful, very helpful. Another question that a number of people asked relates to alcohol and other substance use in teenagers. And where does that fall into play with the issues of anxiety?
So there's definitely a relationship between alcohol and substance use and anxiety, in that many children with or adolescents with anxiety will use alcohol or substances to self-medicate, and that frequently can make the problems worse. So parents and clinicians definitely need to be aware of that, but the association is not as strong as for other kinds of pediatric mental health problems. So things like conduct disorder and attention deficit hyperactivity disorder have a stronger association with substance use problems, and it's particularly the child or the adolescent who has both an anxiety disorder and one of these other problems. That's where you need to be most concerned and most vigilant about the potential for exposure to substances to make the anxiety worse.
Okay. An important issue, important answer. Thank you. Our time is just about up. I want to again say, Danny, thank you for the work you do, for sharing that work in such a clear way for our audience today. I so very much appreciate that. And I want to thank everybody who's joined us today for doing so. All of the research that we fund is made possible through private donations. And if you'd like to make a gift, please visit our website, bbrfoundation.org, or call 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with a family member or friend, visit the webinar page at our website. I hope you'll join us again next month when Dr. D. Bradford Reish of McLean Hospital and Harvard Medical School will present borderline personality disorder. This will take place on Tuesday, July 14th at 2 o'clock Eastern Time. Once again, thank you very much for joining us, and enjoy the rest of your day. Take care.